All right, thank you very much. Good afternoon. Welcome very much to this symposium, which is about some of the activities of the European Diabetes Forum. As you know very well, the Diabetes Forum has been funded a few years ago, and it has really worked very hard in trying to define some line of action that could be impactful in the near future on about the way we do manage diabetes, but even more how we do really integrate and homogenize treatment of diabetes across Europe. One of the main line of work has been represented by the digitalisation, the data registry, and even more the integration and the application and the use of digital tools in order to improve the lives and the outcomes of the people with diabetes. And what has been said is just the title of this session. Now, as I mentioned, this is through the activity of the EUDF. I don't believe that I needed to remind you what the EUDF is, but still I think it's an incredible opportunity for a simple reason that all the stakeholders, the main stakeholders working in the field of diabetes in terms of science, in terms of clinical implication, with the voice of the people with the diabetes and with the support of the industry that is also operating in this specific sector, have come together to try to, as it has been several times said, just have a united, single, stronger voice. I remember I was part of the initial discussion about the EUDF when we were trying to shape, what the EUDF should have been. And I remember the discussion, and I think that everyone's convinced we still needed to improve our awareness about diabetes. Type 1 diabetes is there. Type 2 diabetes is very often considered a sort of a self-inflicted condition, but still this is a condition that is a matter of the daily life of 1 million of people in Europe. So I think that really the major goal of the EUDF has been to bring together all the stakeholders, align on priorities and urgencies, including considering what could be the potential for innovation that is made available for diabetes. Speak, as I already said before, with just one stronger voice, and finally, to be effective and to be pragmatic, in other words, achieve policy results. What this is going to be discussed today is an example. And this is an example that fits pretty well with what is the vision and the mission of the EUDF. Let me just, remind you, because this is important to set the stage and to define the frame of the action of the EUDF, what the vision is and what the mission. The vision is to enable healthcare system to cope with the diabetes pandemic, and I really like to underline this point, the pandemic, while achieving the best possible outcomes for people with diabetes. And again, I'm stressing the word pandemic for a very simple reason, because when you have a pandemic of diabetes and then suddenly you are experiencing another pandemic like the one we had in the past couple of years of the COVID, we come up with a syndemic, which is even worse as a challenge to the system. And then a mission, which is ensure the translation of research into the policy actions toward better diabetes care at a national level. So these are the things that we need really to pursue, and this is what the EUDF has been trying to pursue. And what we are doing here today is to discuss the initial work that has been done by the EUDF. So what today we have two sessions. The first one we will have some presentation, and then there will be an open discussion. It will be my honor to chair this initial session, and this session will start with the participation of Robert Heine, and a long-standing friend, and we have been done so many things together, and he's going to discuss diabetes registry, enabling high-quality diabetes care. Then will be another friend, João Felipe Raposo from the University of Lisbon, that is going to point out which are the 5 priorities for advancing integrated care. And finally, we will have Peter Schwartz and other friends. This is a very good, very nice group of friends, long-standing friends, or if you want, you can call it a small world. This is going to discuss the promise of digital tool, the roadmap for apps. I'm just read up the name of the 3 speakers and the topics, because I would like to invite, the first speaker to come up, and then the next one to come right after they finish. Robert, can I invite you here to the lectern just to tell us about data registry? Thank you very much.
Well, Stefano and Chantal, thank you so much for providing me with the opportunity to chair one of these working groups. And I feel extremely privileged as an Americanized European to lead this working group with the esteemed researchers in Europe on this complex topic. I'm really also extremely happy with the group, because they've been working diligently and with great engagement on the recommendation I will be presenting. So you may think diabetes registries, boring topic. And you are waiting for the digitalization, and you are waiting for the integrated care. But I will convince you of the fact, without diabetes registry, there will be no high-quality diabetes care. So I really hope that you will pay attention to the recommendation. I also hope and expect the European Diabetes Forum will work very strenuously also on the implementation of these registries. Just imagine the scenario: you are driving in your car, enjoying the environment, and then your windshield is fogging up, your brake doesn't really respond very well, and your accelerator is not really very responsive to your foot. The likelihood that you will reach your destination may be there, but the greater likelihood that you will experience a very poor outcome. That's the situation of the diabetes care today. Both healthcare professionals and patients don't know what the quality of care they are providing or what they are receiving. They don't know where they are relative to other patients or other healthcare professionals. And even worse, they don't know where they are relative to all the recommendations. It's driving blindly almost. And we need to change that. Well, Stefano mentioned the epidemic. As quick as we were to respond to the COVID pandemic, so slow we have been with the diabetes pandemic. And we really need to learn from the past. St. Vincent Declaration, I think there are quite a few people who still remember the St. Vincent Declaration. We're also a friendly group, but I think we're also a bit of an Asian group. The St. Vincent Declaration was launched in 1989. Very ambitious goals were set. 50% reduction in complication, and also achieving very stringent treatment targets. 1989, almost 35 years ago. And they also made a very clear statement: establish monitoring and control systems using state-of-the-art information technology. 35 years later, and we are still not there. And I think we really need to change that. So I will cover briefly the value of the registries, the challenges in implementing those, where are we in Europe, and what can we learn from Hong Kong? We really had to go very far to find the best practice. And what are the key principles and the policy recommendations as the last few slides. So in Europe, we do have registers, and I don't want to undervalue or underestimate the value of those registries because they have been extremely valuable in teaching us about the epidemiology, about the natural course of the disease, about identifying key risk factors for the development of complications. So from a scientific perspective, they have been extremely valuable. And we have 4 national registers in Croatia, Denmark, Latvia, and Sweden. And quite a few also more regional registers that have proven to be very valuable. So why can't we be satisfied with those registries? Simply because they're not truly embedded in the diabetes care system. So from a best practice perspective, and I'm sure that your eyes will go to the left graphic, because there you can see something quite remarkable. In more than 750,000 people in Hong Kong, Juliana Chen has been able to reduce complications substantially in a fairly short period of time. And you don't need statistics to see that this is substantial, that it's clinically relevant, and quite amazing. In a few years' time, coronary heart disease, stroke, heart failure, and hypoglycemic crises declined quite substantially. So how was this established? How was this achieved? There was no silver bullet. There was no miracle drugs involved. It was just opening the eyes of everyone involved in the healthcare system. And you can see the diabetes register is not a nice-to-have standalone system. It is truly centerpiece of the diabetes care system. The information is acquired from the electronic medical records, from the labs, from the observations of the healthcare professionals and from the non-physician staff. And the diabetes register will provide you with an overview of the achieved targets for diabetes care. Glycemic control, blood pressure, LDL cholesterol, and the normal, not highbrow variables that we all use for diabetes care purposes. Then this data will be analyzed, reviewed, and appropriate measures taken in order to improve the care by allocating or reallocating resources to make it work. It's a very simple quality control circle, which truly can be scaled to really manage large number of patients. And I would argue, I didn't do an analysis, but this will be fairly a health economic benefit. But more important, the outcome of those patients is much better now than before 2001. So it can be done. Of course, there are challenges, but the challenge should not be a reason to stop. And none of those challenges I will be mentioning should be considered to be a full stop. We need to learn from those challenges and need to learn how to overcome those. Well, first of all, political will, or the will of those that are paying for the system, the owners of the healthcare system. So do they care enough about diabetes care in order to do something about it? So there needs to be a narrative that can speak to those questions. The data quality needs to be assured. Incentives need to be put in place, not only to the payers, but to all the stakeholders. The incentive for a patient to participate will be different than that for a patient. Of course, the necessary education needs to be provided such that people can see the benefit for all stakeholders involved. And very importantly, healthcare professionals, patients need to be trusting the registry that the data are going to be used in order to improve your care and not for other reasons. So the data needs to be put to good use for all the stakeholders involved. In contrast to 1989, I think our digital infrastructure should be at a different level than 35 years ago. So that challenge should be easier to overcome than 35 years ago. The regulatory, this really means, well, we need to put registries in place that are legally compliant and also fulfill all the requirements set in place in order to protect privacy. Importantly, in contrast to science-based registries, the patient care registries need to be able to provide real-time data in order to be responsive to the changes in outcomes. So I hope you agree with me, these should all be overcome. So let me then review the recommendations in the last few slides. The right procedures and governance. So I already mentioned the governance structure. This should be a simple governance structure overseeing the legal compliance and privacy policies. The more important one from a day-to-day practice is to have an executive committee that reads, analyze, interpret the data from the registry and has the mandate to allocate or reallocate resources to those places in diabetes care that lag behind or should be improved. So this should include all the stakeholders, patients, but also the payers and the healthcare professionals involved. So this should be really an integrated group of people that take ownership and have a skin in the game. The quality output need to be allocated to the funding, as I mentioned. I think that's a truly very important part of the registries and the management of the registry. The results and the key indicators on the registry should be accessible. So the data, and it doesn't need to be the same data, but the main stakeholders should be able to use the data for their own purposes. And importantly, we need to identify champions like Juliana Chen in Hong Kong that are ambitious and also motivated to develop and to be the point person for the development of a registry in a country or region where we will be implementing these registries. We need to make sure that nor the patient or the healthcare professional will be burdened additionally by having a register. Everything should be uploaded automatically. And all the systems that inform the registry should be able to communicate. I already mentioned the incentive schemes that need to be also tailor-made for all the different stakeholders. And the validation mechanism is just quality control on the data input, which is important, of course, for the proper interpretation of the data. The registry should be flexible and adaptable, meaning that registers need to be made for the future. If new biomarkers or new findings call for capturing in a registry, that should be made possible. Also, registries need to be able to communicate with other registries. You can think of a cardiovascular registry, obesity registries, other NCDs. We should be able to connect and link those registries in a sensible way. In order to do this, patients need a unique identifier, otherwise it will be very confusing using the same identifier or different identification systems in those different registries. A social security number or something like that, which is very personal, can be used for that purpose. Of course, it needs to be adaptable, as I mentioned, and being able to be updated or amended according to the new insights. And all this learning can be done in a forum where new registries can learn from already existing registries and where shared learning can take place. I think that can be an extremely important tool and actually also quite fun to learn more from others. The implementation strategies, and actually when I was asked to do this, I thought, well, are we going to present recommendations, store them, and then continue with something else? So the implementation is the key word here. And I don't think we should accept anything less than an implementation strategy. I just repeat it again. So we need to mobilize patient organizations because they are the main stakeholders to be involved and to also take ownership and drive the registry implementation. Communication strategy, tailor-made to the different stakeholders. And design registries that are intuitive, easy to understand, where the data can be made such that also patient healthcare professionals and other stakeholders can learn from the data that are presented and also have a clear vision on what to do with them for the future. Finally, the opportunity to thank the working group. It has been for me also a huge learning opportunity. It has been extremely exciting to work with everyone on the working group on discussing, debating the recommendations. It was done all remotely. Still, luckily, I can recognize the working group members in the audience. And I really would like to thank them very, very much for all their input, engagement, and true commitment to this working group. We had long sessions, but always very, very high energy and high quality. I just want to mention one person, especially is Massimo Benedetti, because he was very much involved already in the St. Vincent Declaration, and ever since has been publishing and analyzing and working a lot on those registries. So with that, I would like to thank you for your attention. I think we take the questions and discussions later on. And for me now the pleasure to give the microphone and the platform to João. So thanks so much.
Thank you, Robert, and Chantal, Stefan. It's always good to be among friends and see so many familiar faces. It's my pleasure here to be representing this group. As Robert has mentioned, probably this is the easiest group to speak because I think most of us would feel the need to speak about integration of care, and probably most of us say that we provide integrated care. But at the discussion level, we realized that there were several challenges regarding this concept, and I think most of us are well aware of that. So, I still have this presentation. So, why integrated care? And I think you'll have there 7 reasons that are quite understandable for all of us. So, we think that integrated care in diabetes, as in many other diseases, is integrated to support for self-management, and self-management, as you know, is the key factor for diabetes control and success. It's also the reason to provide efficient value-based health care, another concept that is nowadays very used and still difficult to prove in diabetes. But it's also important to maximize timely care accessibility, and we know that probably different people have different needs, and we know that's true, but we all speak about the integration of care. It's also important, and it's quite correlated with this group here, identify care inefficiencies, and we all know that there are a lot of inefficiencies in our systems. But then we have to have a focus on the quality of life for people with diabetes. And again, most of us would say that we try to provide the best quality of life for people with diabetes, but seldom we have the capacity to demonstrate it. And we'd like to know, or to know if it was possible to ensure clinical care would be integrated with psychological, emotional, and social support combined with our clinical intervention. And finally, it would be fantastic to provide integrated care as a tool to address health inequalities. And we all know that even in our region of Europe, health inequalities still exist and prevail in most of our countries. And so we also identify 7 challenges in implementing integrated care. And the concepts were around sustainability, about our workforce. All around Europe, all around the world, the healthcare workforce is struggling with the numbers of people working in this area. And the needs are increasing, and the number of people are decreasing. The inequalities that I've already mentioned, the financial incentives, and Robert has spoke about finances. Money is always important on these, and money is important for the health system. It's also important for the providers. It's important for all the stakeholders, and the relevance of integrated care on healthcare budgets. But then it's also, and technology in diabetes is increasing, and Peter will be speaking soon about technology and digitalisation. And that brings another challenge to our classical integration of care when we're just speaking about multidisciplinary teams and putting more people on the multidisciplinary team. And now is also to integrate technology and other tools in the system. And still, we have the patient support and education. How inclusive are we of patients, families, and other people in the community, either in providing care or, most important, in designing care? Because we all know that up to this moment, we are still discussing how can we integrate care in classical models of providing health care. And so we are always saying that it's possible to do it in a different way, but seldom we are challenging how our health services are organized or structured, considering that we want to have a focus on quality of care for people living with diabetes, and considering that we want to provide integrated care and trying to avoid that fragmentation of care. And those are the challenges that were identified. And to try to address those challenges, we have those 5 priorities and consider those as a strategic approach to promote that concept of integration care in our region. First one was to develop a framework to assess implementation, because really, we all have a good idea of what we mean when speaking about integration of care, but if I would ask any of you what is integration of care, probably each one of you would say slightly different things, and sometimes many different things, considering different perspectives, different point of view. And so, first point, if you want to address the situation of integrated care in Europe, imagine, we have to know if we are speaking about the same things. And so, as you can see there in the rationale, central consideration in designing and reviewing diabetes services. So to understand how really are the services organized. And that means also to review and assess how well their healthcare systems and delivery process connect with patients and have impact on their clinical performance and efficiency. And as you know, it's still difficult to measure the impact we have in clinical performance and efficiency and in connection with patients when we still don't know exactly what outcomes are we measuring, and still discussing a lot of A1C, glucose variability, endpoint complications on the life of people, and still struggling with concepts as quality of life and other ones. So we considered that it was essential to develop practical and flexible tools, either to support healthcare teams to assess this performance of integrated care, identify areas where integration might be enhanced, and build tools and methodologies to assess performance and added value. Some 5 solutions are appointed there. First one is to endorse the European Commission groups to assess pillars of integration. So if we have a common ground, a common framework of what we mean by integration, that would be a fantastic starting point for this strategy of implementation of healthcare. Then to develop analytical models to understand which areas to prioritize in integrated care, because we know that we cannot address it all at the same time. And the third one, probably one of the most important, at least in my opinion, is to reassess the variables that we use to measure progress in integrated care. And those would include metrics to quantify patient experience, individualized care governance, funding, capacity building, e-health service, and many more. And then the experience of people with diabetes should be central, and it should be really central, not a line in a strategy, but we should be able to demonstrate how are we incorporating the experience of people in this process of integrated care. And then the last one, probably very much correlated with what Robert has mentioned, it's the leverage of data to inform and compare service performance. Second solution, develop integrated care patient pathways. And the rationale, perhaps it seems a little bit strange when we're discussing personalized care, individualized care, but actually we are not here saying that there is a one pathway only approach for people living with diabetes, but actually to know and identify different pathways for different people with different needs at different time points in their life. So the aim is to enhance quality of care, improving patient outcomes and cost-effective interventions, to have disease management programs and trying to avoid the mono-disease centering, and I was discussing with Catherine a few minutes ago about disease diabetes-centered model or person-centered model, and we know that people living with diabetes have many other diseases. How can we really integrate care, not just focusing on a disease model, but in a patient model? And as that, it's relevant to identify key pivot points in the patient journey, to identify those pathways, and those pathways also would help to clarify the healthcare providers, the roles of, we're still working on that levels of care, primary, specialist, clinical, community resources in providing care. But remember, one of the challenges is to discuss the design of services also. Solutions here. Map the integrated patient pathway in diabetes, taking into account social and economic dimensions. Incorporate stakeholders in the process, including people with diabetes, and be sure they are there, and to know which outcomes are important, and then analyze those new metrics that I mentioned also in the previous slide. And the idea is also to create the pathways as something that is clearly understood by everyone, by the healthcare providers, by people living with diabetes, something that, as you can see, could be like a tree with branches and everything. So be creative. And nowadays, we are still terrible to communicate health and disease. And there are some new techniques to do that in a more appropriate way. So why not dare to identify those pathways in new models, not boring models, not the usual stuff that we are used to see every year. And then the last one, it's healthcare providers should be able to adapt pathways to individual needs of people with diabetes. Third, nothing of this would be possible without education. And the meaning of education is really to incorporate these concepts at a very early stage in the training process of healthcare providers and other people in the community. And so a long-term process, for sure, that education. A trained workforce prepared for the future is critical to the success of integration. And so let's move to the solutions. So first, conduct a formal needs assessment to understand where to focus educational efforts. And those probably are different from country to country, from professional group to another professional group. But always be sure that we are speaking about the common language, because sometimes we would make a needs assessment and say, do you know a lot about integrated care? People would say yes. If you don't clarify what we mean by integration of care, probably they would have their own mind and speaking about different things. That's why the first step is relevant in this part. We should have an integrated care curriculum. We should incorporate that integrated care into the curriculum of medical schools and all care professional and specialist training. and then to commission a survey to help to define what other kinds of education are needed to promote and advance integrated care, because we know that, especially in this area, it's never just the pre-graduate curriculum that we should be aiming. We should aim a lifetime continuing education of the healthcare providers and the others involved. Include the development of psychosocial skills in medical curriculum. And that's, we all know that, how relevant this is about the educational process of people living with diabetes, empowering, capacitating people. Train healthcare providers to help them optimize their communication skills. Still missing. Monday I was in a session here. There was a questionnaire for people living with diabetes. What were they missing? Communication with their healthcare providers. Still saying that's still difficult. So almost 100 years, more than 100 years after the insulin, people are still fighting exactly with the same points. Almost last, target educational efforts to all people involved in the implementation of integrated care. So be sure that all are on board. And then focus on organizational learning. If we just target one people at one community, at one health center, at one hospital, at one service, that will never work. So we'll have to be sure there's a commitment at organizational level. And then it's money. And again, and money is important, and we should discuss money. So financial models are too focused on systems and not patient-centric. We all know that, but still difficult to find the right model to prioritize integration of care. But so we need to align financial incentives to encourage providers to work together towards integration, to move towards a model focused on health outcomes. And so, solutions. Develop incentives for all providers and stakeholders to participate in the integration of care. At the moment, we still don't have those tools, so it's a challenge also for this group to find the right model for incentives. Align or pool budget to enable clinical integration, reduced fragmentation, and deliver patient-centered care. We should be able to link payments to outcome metrics to incentivize the focus on service delivery. And lastly, use the European semester as one of the guidelines, one of the monitoring capacities in the system to guide the member states in transitioning their healthcare systems. And finally, the implementation strategies, as Robert also has mentioned. We need to promote integrated care in a more digestible and intuitive way. For that, we should develop a clear and concise narrative. Still difficult to speak about that if you don't have, even between ourselves, a clear and concise narrative. And then we should tailor this narrative to the needs of different groups and organizations. And then stimulate stakeholder engagement on integrated care using either the traditional methods or be a little bit more creative. And then redefine the patient satisfaction from the perspective of integrated care. And for that, we felt the need to encourage more research to quantify patient experience and to measure outcome improvement in integrated care. So, final slide, just to acknowledge the chair of this group, Angus Forbes, that you should be here doing this presentation, but I felt honored to be in his place, and all the members and contributors to the working group. It were lively discussions, remotely but lively again. And so I think we all felt very happy with the final result. And a special thank you also to Bart to keeping this session and everything so perfectly done. And with that, I think I'll pass the floor to Peter. Peter, it's your turn now. Thank you very much.
Yeah, Joao, thank you very much for giving me the turn. First, I would like to thank Chantal and Stefano that EASD was supporting this activity of EUDF. And it's a great honor for us today to be here and to have the past and the future leadership of EASD in one room to discuss all these topics. Like Robert has said, like Joao has said, there are numerous unmet needs if we discuss or if we talk about diabetes care. We sometimes believe, yeah, it's working. It may be working if I'm as a physician in the practice and I prescribe my drugs and I see my patient. But if we look into our health system, if you look into the challenges of our health care system, of chronic care management systems, with the eyes from our patients with diabetes mellitus, we find numerous unmet needs. And This was also my understanding in working in the field of digitalization or steering this strategic forum to focus on what is the unmet need in the field of diabetes care if we look with the eyes of the patient onto this. And I remember it was very early in the stage as we discussed about setting up this forum, and I had the discussion with Chantal about how to build this up. And I said spontaneously there are two things important, and this is quality and accessibility. And this was somehow the red light or the red line, not the red light, the red line through the work of our working group, that we say, okay, if we really want to implement or embed, and this is in my eyes, this is a better word, embed digital solutions into the care pathways for patients with diabetes, then they must have a very good quality, a quality we trust, and they must be accessible. Because if you have excellent digital tools and no one can use it, or they are not reimbursed, or they have the wrong language, or they are not addressing cultural and intuitive needs of the patient, it will be a failure. So from the beginning, these two words, quality and accessibility, were driving us. But throughout the process of the working group, we have changed this and we said, okay, it's sometimes difficult to have two words. It's better to have only one slogan. And we translated into the slogan, best practice scale. Because this, in our minds, better describes what we would like to reach. So we want to have best practice in supporting our diabetes patient in their self-management by using digital tools. But we also want to scale this up in Europe to make it accessible to our patient with diabetes. Now you could say, okay, why is he talking about digital and so on? We have good drugs, we don't need this. If you look into our guidelines, the guidelines from 2019, it gives a clear statement about digitalization. It says, we as healthcare provider or healthcare practitioner, as physicians and the diabetes team, we should know about strengths and weaknesses of apps, how to use them for our diabetes patient. We should use them, it's the second point, in terms of improving diabetes care and supporting lifestyle of our patient. And the third point is we should use the data in the app to improve the quality of diabetes care. And here you already see there is a challenge for us given by our guidelines. And normally if I give a lecture, I ask all the colleagues, who is doing this? Yeah? And most commonly you get the answer, we are not, because there are different numerous reasons for it. There are challenges we have to address, but it's not our reality yet. And this is the second red line in the work of our group, that we said, okay, we want to enhance the capability that we as healthcare team, we as diabetes team, understand digital tools, use digital tools, understand in which patient is it, what kind of tool better working than another one, what is the patient with a good digital literacy for what tool, and how is it with the digital literacy on our side as physicians. And this was the wrong button. And this was the start of our work that we said, okay, what are the benefits of apps? And if you look at this slide, it says we can track things like glucose and medication, but we also can track like social environment. Yeah? If we know that peer support is the most powerful support a patient can get, enhancing peer support, tracking peer support, initiating peer support, or also tracking the environment, the lifestyle, the behavior of the patient can become very powerful if we include this into our therapeutic decisions or therapeutic strategies. Access to care. We have just heard about how important it is to integrate different strains of care into each other and what are the unmet needs there. Having a digital tool which can provide the databases to do this, to track this, to test the quality of integrated care can be very powerful. Communication within the diabetes team, telemedicine, e-prescription, but also using digitalization as a delivery channel back to the patient to support motivation, to support and enhance self-management, and to give the patient examples how to improve diabetes care. And of course, finally, there is a big branch, if you're talking about the apps, in terms of data. There are so many data stored in our apps, and this is in Germany, I would say it's ein ungehobener Schatz. I have no idea how to say this in English. Maybe it's something golden in our hand if we would know how to use this for our diabetes patient. And we need rules, we need quality, we may need classification of this to optimally embed this into our diabetes care process. Wrong button again. But there are challenges. And if we talk about, I would say, digiceuticals or digital therapeutics in diabetes care, then it's maybe a new class of drug, maybe a new class of intervention which we have not foreseen. And of course, there are challenges. There are challenges like, I already mentioned, quality of this. Is an app you find in the Play Store and the App Store the same like a digiceutical in diabetes care? What is about the evidence? Do we need exactly the same evidence like we need for a drug? Or do we need actually better evidence for a digital tools compared to a drug? How does this study has to look like to provide evidence? Is this a classical RCT or is it different? Integration, how can be a digital ceutical or digital therapeutic be embedded in the classical healthcare processes we are working in? Is it an autonomous or autark part, or is it truly embedded into the healthcare process? And if we talk about digital solutions and we see it as a drug, we as, I apologize for saying, in our narcissism as physicians say, okay, we have to prescribe this. A digital tool must be the same as a drug, and only we have the right to prescribe this. But if you look with the eye of the patient, suddenly we experience a kind of paradigm shift that a digital tool downloadable in an app store with a good quality is directly accessible to the patient. Thus, this maybe opens doors to different processes in healthcare, different patient-centered chronic care management processes in digital diabetes care. And I think this is a fascinating topic to discuss, and this was also something we have intensively done with pros and cons in our working group. Data security, interoperability. Imagine a patient is using an app and he's using a different app. It would be a dream that he can transfer the data from one app to the other one. I live in Germany and we are a disaster in interoperability in healthcare. We have 158 different kinds of softwares available in the healthcare diabetes sector, and there's absolutely no interoperability from one system to another one. So this is a very important point to address. Attrition and digital hesitancy. Other aspects, I mentioned already digital literacy of the patient, but also the digital literacy of the diabetes care team becomes very important. Our experience is the digital literacy of our patients is better and bigger than those of the colleagues. Somehow I always press the wrong button. And this work has led to 3 groups of recommendations. And we are not talking so much about this is implementation, this is relevant for this one and this one. As I said in the beginning, we are looking onto it with the eyes of our patient, because in using digital tools, the patient-centric development or the user-centric development is, I think, the main challenge we have to overcome and to address. And this is already the first recommendation, the development of user-centric digiceuticals. And this starts with the design and technical specification. Patients with diabetes have to be involved from the beginning. User-centered design process means nothing else as ask your patient, ask your patient because they can give you the right answer. If the app is designed that the physician is totally happy with the app, but the patient is not using it, it's a nonsense. And why is the patient using it? Because he likes the design, because he is motivated into it, it's a good interaction, and the patient can tell you how this should be. And this should be user-friendly, easy to navigate. Have in mind that our target clientele is not the 23-year-old Facebook or Twitter user. It's probably the 67-year-old lady who wants to use this product. Data security must be safe and data must be interoperable. We can provide a first generation of 100% interoperable healthcare products if we correctly address these challenges. But also, what are the objectives of digitals? Most people think in the first moment it's an app using glucose data together with a sensor or something else, or it's monitoring blood pressure. We can go far beyond. Why? We are in the pocket of our patients. We have never been so close by using a smartphone to our patient than being in the pocket of our patient. If we now stop at the point and say, okay, we translate our classical processes into digital, we will lose a lot. But if we think and say, okay, if we are so close to our patient, if we understand this, if we develop new strategies and give at the right moment for the right patient the right impulse to change lifestyle, to enhance self-management, to give aspects for motivation, this would be the right objective for a digital tool. So the apps should focus on empowering people and offer better support and motivate for improved self-management. It should be personalized and individualized, so the patient should have the feeling this digital is exactly doing what I need in this moment. And this is something that is far beyond going compared to once in a quarter visit with the physician. The data collected should be relevant and actionable. So the patient should use or should store data where the app is doing something what has a benefit in terms of feedback or direct benefit to him. Second recommendation, and this is related to the aspect best practice scale. So it should be the best practice we are supporting to scale up. And this is first the accessibility. The best tool means nothing if it's not accessible to the patient. And it means not only that it's accessible to a patient in one country, it means accessible to patients with diabetes in many countries, in different circumstances, different cultural backgrounds and so on. And this means in comparison with evidence, we need strategies how to register, how to license, how to build evidence for digital tools. And each member state should build up a process like this. In Belgium, in France, and now in Germany, processes exist. We have 19 different digiceuticals in the diabetes sector in the pipeline currently. It's fascinating to see this, but this process of licensing is something that is needed. People with diabetes should be consulted, and PROMS, so patient-reported outcome, is probably the main driver in the future about the quality of these tools. They should be reimbursed. So it should become an integral part of our healthcare delivery with reimbursement if the app proves that it has a real value for the patient in connection with the healthcare provider, and also real-world evidence will become in the future a main point or main objectives in determining the evidence of digital tools. And finally, it would be not true to say that we as physicians are 100% prepared about the apps which will come. We are not. We tested this in Germany, and from 100 physicians, 7 say they are using this and are prepared for this. So we need education for ourselves. What will be the right app for the right patient in the right moment? The practice today is the patient is coming and say, doctor, I have here 3 apps, and can you tell me which is the best one? And the doctor doesn't know the name of the apps. So this is something we have to change, and there's no one better than our associations to build up this educational platform, this educational initiatives, and to use maybe digital strategies for training to enhance the knowledge of the healthcare team about this. but we also have to encourage the uptake. We have a disastrous situation in Germany currently that the government says we give a very good reimbursement for apps. So everyone was totally excited. But what happens now? The physician says, no, I don't prescribe an app if they get 500 euro reimbursement, and I as physician get only 48 for the same period. So there's a kind of jealousy just coming up. We can say, is it right or not? I don't want to make a statement about this, but this is becoming a clear barrier for the uptake of digital tools in Germany, so we have to solve this. And all the aspects written down here, how they should be prescribed, how data should be used, how incentives should be given to healthcare providers, what kind of payment models should be used, and how this should be engaged with medical societies, so with our society, to basically build the way for scaling up the use of apps. But our ultimate goal is that they are, as I said at the beginning, embedded into our classical chronic care management or healthcare structure. So it's not something unique, it's part of the healthcare. And we are sure that these apps can play a very important role, and the power of this role is behind the personalization and individualization of support and motivation by using an app. We can collect and provide data, maybe for initiatives like the registries, maybe for initiatives like the integrated care, by withdrawing the data from the app. And if these apps are validated, provide data in maybe RCTs, in real-world evidence trials, so that we are sure and have a good evidence about the quality, then I think we should take the next step and implement recommendation how to use digiceuticals in diabetes care also in our guidelines. And with this, I would like to thank all the people participating in this work group. It was a great honor to chair this group. And if we have 3 slides here, it doesn't mean anything about the discussion. We had a very interesting discussion, controversies, pros and cons, and disagreement and agreement. And it was a very powerful basis to have members in this group from different backgrounds, different in-streams. And I'm very proud that we can present this data now, and I hope that the liaison with EASD and the other organization will ongo so that we finally reach best practice scale in diabetes care. Thank you very much.
Thank you very much, Peter. Thank you very much, Joao. Thank you very much, Robert. I think that this is a very nice summary of the intense work that's been done over the past couple of years. I think it is not simple to summarize everything in such a short time, but I think that the main lines, the main elements for the discussion has come up. So you heard there have been 3 workshops, 3 pillars, as has been called within the EUDF. The work is there, so what's next? Next is implementing those, is implementation. And implementation, of course, requires further work and further discussion. And this is what we are going to start now. I'd like to invite the President of the European Diabetes Forum, Professor Chantal Mathieu, to coordinate the discussion.
Thank you, Stefano. And if I can actually ask the 3 presenters we had today to join me on stage. And I also will invite more people to come to the stage. So Joao, Robert, and where is Peter? Ah, Peter. You're completely blind when you stand up here. So please join us for the discussion. And then I will invite Dr. Jeannette Soderberg from JDRF. She manages the rich JDRF European portfolio. She's playing a home game because she is located here in Sweden. I will also invite Dr. Katarina Egg Olofsson. She's the senior consultant at the Diabetes Clinic Institute of Medicine at University of Göteborg, I should say, yes. But you're here because you're also the director of the Swedish National Diabetes Registry. And then I also invite Dr. Pinar Topsever. Where's Pinar? Hello. Pinar is the vice chair of Primary Care Diabetes Europe, and she is a professor of family medicine and primary care herself. And then I miss Tadej. Where is Tadej? Ah, and I miss a chair. I miss a chair. So Tadej, will you stand? Ah, there's one. I don't see it. Oh, voilà, Tadej, my dear friend, Professor Batellino from Ljubljana, who is a professor of pediatrics and, as well, most of you will know, an expert in novel technologies. Thank you, first of all, to the three speakers who presented and again who participated in the strategic forums we had at the European Diabetes Forum. I will also tell you, the audience, please join into the discussion. And as you can see, we have different stakeholders here, and the most important stakeholder is missing, and that is a person living with diabetes. We had invited Kajsa, and I forget her last name, Kajsa Lindberg, also a home player, to join us in this important discussion. She is working very actively with one of our members at EUDF, namely the IDF Europe, but for different reasons, Kajsa couldn't join us today. But so if there are people in the audience who want to voice also the voice of the people living with diabetes in this whole discussion, do join in. Can I start, first of all, with Katarina, before people come up to join into the discussion? Robert gave the example of Juliana's work in Hong Kong. You, with the Swedish Diabetes Registry, we have interviewed you with the European Diabetes Forum and the Strategic Forum on data and registries to also give your example. What has the Swedish Diabetes Registry contributed to changing the way diabetes care is organized in Sweden? Katarina.
Thank you very much. It is a big question, but I will try to answer. I think, Robert, you started off very, very well with the St. Vincent Declaration, because that's where really the founders of the Swedish Diabetes Register, they started there. They wanted to really reduce the risk of complications by really focusing on excellent control of the glycemic control and other cardiovascular risk factors. And this has been an ongoing work since 1996 when it started. And today we have both the specialized care with type 1 and type 2 and also primary care in the register. And I think the idea now is that it's very integrated in the Swedish system of diabetes care. That the value is that actually the healthcare units use the registry data, their own data, they compare with others. The diabetes nurses are a very important part of the diabetes team, doing a lot of on-the-floor work with the patient and to improve the risk factor control. That is a start, I think.
Okay. Robert, you alluded to it already. Who should pay for the organization of this data collection? I mean, and this is not everybody's, but it's not a joke, because it's I mean, again, I see my colleague Professor Frank Nobles here in the audience. In Belgium, we also have a Belgian Diabetes Forum in the meantime, with the example of the European Diabetes Forum, but we are struggling with that, and we thought it was actually the government, thus all of us, the society, who should really put efforts in having registries. But if I could have your opinion, Robert.
Yes. So that's why I refer to the governments and the payers. However defined, and very dependent on the country, the region. So before the symposium, I also asked John Bruce, and I spoke with Bob Gabbe earlier. And this is also an American question. It is a European question. It is a global question. And the healthcare is paid for by different entities in the different countries. So it is really not dependent on the government. It is really dependent on the owner, payer of the healthcare system. Mm-hmm. And so that's why when we spoke about the registries, it is up to the registry builder to discuss with the payer of the region, in the region or in the country, to make it also create an incentive and to make it attractive to the payer to participate in the register. It's not just to pay for it, but being a co-owner and a participant in the build, the interpretation and the allocation of resources based on the outcome of the registries. So it's not just paying and then move away. No, it should be an active participant in the diabetes registry. I hope I answered your question. Or the reason I smiled, Dutchmen always asked about money. So,
no, to me it's a no-brainer that the entity that pays for care should have benefit in knowing what they're buying.
Well, exactly.
And so in trying to improve, but also improve cost effectiveness. If you have the data, you will improve the way it goes. So, Katarina, how does it work in Sweden?
Yeah, Sweden is a small country. We're at 10 million, and the system is publicly funded. So, of course, it's the government and the regions that really pays for our care, and they also pay for our registry. So we are funded from national means.
Jeanette?
No, I completely agree with both Rob and with Katarina. There is one challenge with this, which is that we do have a fragmented system with different payers in different regions. And if we don't coordinate this, and if we don't make sure that we have an overarching objective of having a national registry or an international registry or at a higher level, we're going to end up with 10, 12, 45 small registries with not enough data to be able to analyze. And also they might be collecting different things, and then we're actually not achieving anything. So while I do agree that the payers must have incentive and they must be the drivers of this, if we could have a coordination at a higher level, we would be much better off.
Yeah, Robert, I think you reflected on that, in your strategic forum, that you can have the registries at national or regional levels, but then they should all be able to come together to make sense.
Well, it definitely makes sense now and in theory, but let's start with baby steps and show first it works, it can be done, creating the confidence it can be done, and then go to the next step. I think we also need to learn again from the St. Vincent Declaration. You can't expect the globe or Europe or a country to build a system that's foolproof and can be activated immediately. Yeah. We need to learn stepwise.
Excellent.
And I think that makes it much quicker because at the end of the day, you have a system that works where people are confident in participating, and then you can link anything together.
Yeah, I'll give the word to the public, but first, Peter, brief comment.
Yeah, I want to share a short experience from our working group in the digital field. If you have this registry aspect in mind, we are commonly discussing registries which are filled by the healthcare system. So from us as physicians, from nurses, from health authorities. But if we flip this and say, okay, there are apps the patient is using, and they provide the data so that it's like a bottom-up approach. It could also fill a registry. It's a different model than we have in mind currently, but it also could be an option gained by the development of digitalisation currently.
Yes, please. If you can just introduce yourself and where you're from, because this is being taped and will be available not only at EASD.org, but also on the EUDF website in a few weeks. Yes, please.
Sean Devine, I'm from Galway in Ireland, and we don't have a national diabetes registry. And although Professor Heine had a circle of the challenges and didn't rank them, I think there is a ranking, and political will, I think, is the number one. The problem, as I see it, because I've been advocating for this for a number of years and we haven't really been able to progress it, is that the political cycle is 1 to 4 years. And the life cycle for diabetes and its complications is much longer than any government. So that's one comment. And the second comment is that, you know, politicians understand short, sharp messages. In Ireland in the mid-90s, we got our Cancer Act together and we have an excellent cancer registry. Chronic disease is the new cancer, is a phrase that I have started to use when I'm speaking to politicians, which isn't very often. But something like that for EU Diabetes Forum, it has to resonate with them. They just don't get it.
Well, thanks for the comment. And I think we really need to be reflecting on why we have been failing the last 30, 40 years. It's easy always to blame the politicians, but maybe we haven't been very successful in our narrative and the way we have been talking with them. And I think there are a lot of issues that we are fragmented and we contradict each other, and we may not even take it seriously enough. So I think we need to be also reflecting on that. Cardiovascular disease and the cardiologists have been more successful than we are. So maybe we can learn from them as well. Not everything, but at least some of the good things. And so I think we need to get our act together as well. I don't want to blame the politicians, because if you speak with several of those folks, they listen very carefully, they want to collaborate, but they also have their issues and their budgets and their priorities. But I agree with you, we need to be much more mindful and much more precise in our narrative and be more active and proactive.
Can I fully agree with also our style of communication? I think it has to do with the reasons we chose probably endocrinology and diabetes care. We are very balanced and careful, and it can be this and it can be that, and we need to be balanced in our messages. The cardiologists just say you die if you don't take care. And indeed, cancer, you die. And so our messages, and it's a pity Angus Forbes couldn't be here with us, but he always gives this example of a dying little cow that was used to bring a message, and then all of a sudden the whole country paid attention to the way you know, cattle was slaughtered. Anyway, but so we are very nuanced in our messages, and yeah, I think we have a little bit of hesitance when we speak to politicians and our balance. But Bob Gabay from ADA, please, Bob.
Thanks. So I want to follow up on the registry idea and make sure we're get your thoughts on this. So in many ways, it's sort of necessary, but not sufficient, right? It provides the data, but at least for most health systems, they need some technical assistance, some guide on how to take that data and start to improve. And so probably a number of you could comment. I don't know what's happened in Sweden in that realm. You know, I know Juliana Chan's work. You know, there was a lot, it was the registry, but it was a lot of other stuff on top of it. And we don't want to underestimate how important the registry is, but also how much other work needs to be done, which is usually a lot of heavy lifting.
I can just comment on it, is that it started from the healthcare professionals, I think was a very fundamental piece in the whole success, that it really was factors that clinicians wanted to measure and knew were important to their patients, and that sort of was the driving part. The funding from the government was not from the start, it was from the professional organization to start with, for a number of years, and then showing that it really mattered in different regions and that you could improve diabetes care from different parts. That made the payers more interested, and now they're supporting the work. So, but I was just saying, when it says how important it is, we have been working with the Swedish Children's Diabetes Register, so doing from children to adults, and that we see the whole thing as one, because for children we kind of get the same cancer feeling, that this is very important. So working with pediatricians have been a success for us.
Can I just ask, Robert, one of the points you also had in your solutions was this oversight of a committee, or I don't know what, a forum you called it, overseeing data and driving to do something with it. Can I just give the example of how COVID was handled in my country? Sure. It wasn't fantastic, but still, they had everyday data. But there was also a committee interpreting the data and guiding what happened to the data. So, Robert, this concept of doing something with the data, as Bob is suggesting.
This illustrates that when we have a pandemic like COVID, we can be very responsive. So Bob, when you say, well, is it, of course, the registry, I would even say it's stronger. The registry is critical, is essential. That's why I used the analogy with the fogged up window shield. If you can't see where you are driving, no one cares. If you can't deliver the data to any payer and they don't know how poor the care is, seeing the data from the last 10 years in the US, where we see deterioration of the quality of care, it is embarrassing. If you would see those data monthly, you would do something about it. Or you would maybe seek another job. But having data that show that you are driving in the wrong direction makes you think. And I think that's the first key value a registry brings. And then to Chantal's point, and what I try to point out, there needs to be a committee or overseeing, whatever you want to name it. The stakeholders need to act upon the data they get. And that is the quality circle. It is not rocket science, but it is heavy lifting, for sure.
So can I just, again, in Europe, there's a lot to do about the health data space. And, when Bart Torbijns and myself talk to these European people, they say, oh, but everything will be solved with health data space. So my heart starts skipping a beat when I hear that. I see Jeanette also nodding. Can I have your comment on that? And let's turn it positive. How can we exploit their initiative?
I'll start negatively first. No, but we do know that there's a lot of initiative of collecting data. People understand that data is important. There are buzzwords around big data. It's been around for years. And honestly, what we're collecting isn't big data, so there's not a huge amount coming out of it. And just collecting data in a registry in and of itself is never enough for anything. You can have huge amounts of data. It's the implementation, to Bob's point, that is important. And we do know that some of the smaller regional registries collect fantastic data, publish fantastic papers, but the quality of the care isn't improving as much as the research output. And it depends a little what you want to use your registry for. But in terms of how we portray this and how we make a change on the positive side, especially at the European level, we must take advantage of the fact that they have currently understood that they need a pan-European overarching health data space for different types of diseases. They are starting with cancer, breast cancer, cancer imaging, and we as a community need to push as hard as we absolutely can to make sure that we have a health data space in diabetes. And I think that there are chances now. They're currently exploring different new areas for these health data spaces. This is the time to act. It's now we need to push.
Yeah, could I just, again, with the European Diabetes Forum, we have been bringing to the attention calls on non-communicable diseases, joint actions and what have you that are happening in Europe. But it's the member states. So It is all the states who need to apply and who need to bring forward their initiatives. There's money in Europe for each individual country to make these registries, or to collect data, or to do something with the data. And again, please go to your individual countries, talk to your politicians, talk to the systems that are in place by the payers, and make them aware of the calls happening in Europe so that they can participate. Because, it is our member states that need to react. Yes, please.
Small. I have a question mainly regarding Germany for Professor Schwartz, because I live there. If we already get someone to pay for the registries, do you have any ideas on how to motivate or give incentive to the patients so that they actually use the apps? Because at least we're having, my colleague Marta and I were doing a study called Protein, and we have developed an app as a consortium, and the app works well and everything, but the problem is to get the patients to actually use it. And because in Germany you have the insurance companies that give you bonus programs and money as long as you use all the wearables that you have. But the patients that I would actually would like to see them use it, they don't. And that's the hardest part that you have in the real life clinical work, at least.
Thank you very much for this question. If we start from the point of registries, there is no national diabetes registry in Germany. There are some local registries, and they follow the model what was just presented to say, okay, there is excellent data collection, but the interconnection, how to improve care, is missing. So this is, in my eyes, the main missing step. Having a registry where the data are dying makes no sense. I apologize for this word. If we now jump to the apps, what you just have described is a key point, and this is what I try to describe as a user-centered design process. There are millions of apps available, but if we ask the question, what are the apps the patient is using? You don't see it in the App Store, maybe on the number of downloads, but the patient decides intuitively, do I like this or not? And we all do. And we are not different than our patient. How often we download an app, we look at it, and we delete it again. And a health app or a diabetes app, or in Germany we call it DIGA, is not different. And so this is what we, I think, have to learn. If we develop those, we have not to ask the IT people. We have not to ask us as physicians or the insurance company. We have to ask the patient. And if we do it, it will not be a guarantee that we will succeed, but it will be a high probability that we do the right thing. I hope this answers the question a little bit. I was jumping and turning around.
I know the DIGA, but the DIGA is barely used by practitioners or diabetes educators.
Because of this aspect, I don't want to go too deep into it.
Specifically for Germany.
This is very special in Germany. We were so happy as we saw that the healthcare system is prepared to give a high reimbursement. We thought now the dream starts. But then suddenly the main player in the system, the physician, said, oh, no, I don't do it. And it was totally unexpected.
Thank you.
It also needs integrated design and integrated decision-making. Tadej.
Thank you very much. So first, it's funny that I will defend Germany in front of you, but Germany actually has one of the best registries in the world. That's called DPV. It's a pediatric registry. It happens same as you mentioned, and I believe most, if not all, centers from Germany are participating. There are New England Journal publications out of it. So it's perhaps one of the best examples how a large country actually can unite and use data. So there is no dead data in this registry. There are 10 or more publications a year actually out of this registry. So just to defend Germany a little bit. And then it's University of Ulm. No. And number one. Number two, Germany was able to attract approximately 70,000 people from around the world to do the SWIT registry, which is also managed by Ulm, by University of Ulm. and is now perhaps the biggest registry of individuals with type 1 diabetes in the world by a margin, right? And the Swedish registry is participating in the SWEET initiative and many others. So I will do the positive side of what you're saying. And the SWEET registry is publishing more than 10 papers a year also, some of them good. What's most important is there is a benchmarking inside the system, and there are yearly conferences actually to use the benchmarking to improve. And a 10-year analysis of all people in the registry showed an improvement in A1C and time in range, which means, number one, data is collected, number one, it's calculated, and number three, it's used to improve the practice. So all 3 points that you so nicely described. So if you want, something, positive, this is positive. And, for your surprise, it comes from Germany.
Yeah. But I hear now different remarks saying that successful registries are the ones that start from the bottom and not from the payers, but really with examples coming from the healthcare, from the HCPs, from HCPs like pediatricians, etc. And perhaps that is, that's also the path we're taking in Belgium, where we're trying to give a good example. For more than 20 years, we're collecting also data as quality control in people treated with insulin. But perhaps we first need the good examples to then go to the politicians rather than go with our narrative to the politicians.
So true.
I think we have the good examples. I don't want to wait another 5 years to set another example. So let's use even the German data to convince politicians elsewhere that it is really required. I don't want to wait another several years.
No, you're impatient.
Yes,
I understand.
I'm losing my patience.
Zhao, and then we need to go to the audience.
Well, I'd like to make some comments. One is about sustainability of the registries. Because many of you spoke, Chantal, about EU-funded projects, but the word project always give me a short-term life for a registry. And so I think we should be aware that we want to create registries. We want to be sure what registries are for. So it's just not registries. And I think one of the successes of the suite from the beginning was we were very sure what we wanted the registry for. The questions were there, the reporting was centralized, analyzed, general meetings. So all the process was there from the start. If we're just speaking about creating a registry, in most of the healthcare professionals would mean extra workload, no feedback, no reporting, mass data. So if you don't offer to the healthcare provider side what we want to have the registry, what kind of workload they are supposed to have, and actually Peter was speaking about we can probably feed a little bit of the registry with data coming from patients. And I still don't understand why most of the data cannot go automatically from the electronic health records and start this discussion. For most of the people, we are still thinking about registries as something running in parallel with the patient records or electronic records. We should struggle for that combination, for the operability, to have the common data to analyze. That was something that happened in Suite. And for the sustainability. So it's something that should be there and should be there to answer questions. And questions can evolve, but at the start we should be very clear what questions should be solved, answered, and compared. And actually the feedback to the providers and the feedback to the people living with diabetes is probably the most important, because if people feel this was important for me, for my practice, they would push the system to keep the registry working. Otherwise, we just die for the 4 years project of the funding or something like
Peter,
that.
I'm going to ask you to hold your question, because we have 3 people in the audience waiting. So please go ahead, introduce yourself.
Yeah, Henk Veese, Diabetes Netherlands. I agree, let's say, that systems should be able to forward the data. An example is DPV, Tadej gave, but it is also forward to the suite system, where there's now worldwide collection in pediatric data. It consists of tens of thousands of data pieces, and it's feeded back to the clinicians, actually how they behave compared to other clinics. The feedback for patients, I like to make, and that's my point, is very important. What went viral with us is the upload of devices and feeding it back in a readable format for patients. And we now build cloud care as a data silo, brand agnostic, using all kinds of data coming every day from different devices in one silo. And just like Eurocontrol with the planes, we have an overarching nursing staff looking at it, where there's deviations and targets, and where you can postpone a visit, where there is no need to show up. The glucometrics is really the data set which matters to make change for the patients in a direct, let's say, patient interest. That is a really core facility. Now I come to the business case. If you can reduce visits and you're paid for 4 visits a year, and you grab that money and you can hold it in your clinic, and you reduce visits, then you need less staff, you become more efficient, and you get the registry for free because you can easily pay for it. So also look internally at the possibility of the business case. And the other message is, what's in it for the patients? That's a key factor to make them part of it. And the annual review data on your cholesterol and so on can be added later. It's one time a year. It's relatively simple. Glucometrics makes a change.
Yeah, and again, Pinar, I think in the integrated care forum, you have discussed what our colleague from Diabetes was alluding to, namely that we need different ways of payment for chronic disease management. Because in his system, he gets a ballpark, you know, a ballpark figure, just poof for 1 year, and if he can save 3 visits, that's money for the center. In my system, I only get paid when I see the patient. So if I have a nurse looking at glycemia and I don't shake the hand of the patient, no money. And I need to spend the wage of the nurse. So can you respond on this concept that data registries go hand in hand with integrated care and payments of systems?
Payment is maybe the last thing I would like to comment about, because that's always tricky. But of course, without data, without registries, I mean, data make up the registries. Registries should never be a project. It should be an organic, inherent part of every healthcare system in every region and country. So they should not be dependent on an EU project and its 3-year or 6-year payment cycle. So first of all, that. And all countries do have health records. They might be electronic, they might be hard copy, handheld, whatever. But we do in healthcare, everybody has health records. What I believe, and I learned a lot during our 2 years collaboration, online collaboration, what I believe is a very good approach, make it simple and elegant, to have a core data set, let's say, talking primary care now, a core data set in primary care, and thinking about diabetes as the index disease in a multi-morbid, elderly, polypharmacy patient. And then we could have in secondary care, specialist care, of course, on top modules of that. But what's very, very important, I will talk about the money, don't worry. What's very important is that we have vertical integration of information flow, and that is not possible without registries. So who should pay for it? I think, of course, the healthcare system, the government. Thinking of my country, that would be the Ministry of Health. And in terms of reimbursement of healthcare professionals, I think Zhao beautifully referred to that. We discussed in our integrated care forum that the future lies in financial incentives for integration of care, not, you know, the examples that we were just hearing about, that you get paid per service or paid for outcome in the disease management programs, and you have the benchmarks. Again, something very, very nice that registries and data do enable us to do, to benchmark my clinical performance with people with diabetes. I provide care to with my colleagues in the region. So not only the outcomes, but the whole integration of care should be also financially reimbursed. I guess that's what our working group decided on, and I totally agree.
Interesting that all the pieces of the puzzle need to come together. It's integration, it's digitalization, it's data. Frank, please introduce yourself.
From Belgium. In fact, throughout Europe, we have vast amounts of data. And all the nomenclature data, for instance, to be able to pay the caregivers. The crucial point, however, is that we don't know very often who are the persons with diabetes. So the key point is how to identify people with diabetes and then link them to all the existing vast amount of data that we have. So I would like to have your opinion on that. How are you thinking of identifying people with diabetes and that they also give their consent, that this identification is used for purposes of quality improvement and linking with other data?
Tadej.
I may reply. I'm from a super small country, so it's easier, and I agree with you. So all of a sudden, since last June, the government is paying for registries, different registries, and for integration, because they have now a central depot of all data, and yes, you get identifiers that you can pull them together. So perhaps, the recent times helped us a little bit, and I very much agree. As a small country, if you build your registry on an open frame platform, actually, you can connect to others. And also in regions, in larger countries, I agree local is easier, that's for sure. But then if the platform is open and it's connectable to others, you can integrate later on, which is what you're referring to. So perhaps this really is a good model, that you build several local registries like, Sweet did, or like, Type 1 Exchange did in the United States, by the way. You are saying all is wrong. It's not all wrong. I mean, they have Type 1 Exchange that works. And perhaps it's just, now that we learned more, a chance that we build on it and do what probably we all want and agree.
But so primary care is indeed key, because there, especially people with type 2 diabetes are sitting, and so labeling them correctly, labeling is a bad word probably in English, but identifying them correctly as having diabetes so that it is traceable is probably crucial. I need to read your body language from your backs because I don't see you. But João, are you proposing to say something?
I was just to say that I think there's a problem there with the crossing data and matching data between systems. At least in my country, that's a problem. While it's easy that at primary care, people living with diabetes, they are classified as having diabetes. It's not possible to match those with other health data or other social data. I think what Chantal has mentioned about the European Health Space Regulation probably would clarify a little bit more what's possible and what's not possible, concerning that people, they own their own data and they can give the permission to cross-talk between systems, but that's something that's not happening, at least in my country, and that's something that we would need very much.
Can I just, before Peter speaks, I mean, if we say, Europe, we don't need your money for diabetes, the cancer people will say, hey, thank you. I mean, Jesus Christ, use the money. So don't say, we don't need it, we'll do it ourselves. I mean, Peter.
Yeah, Chantal, just coming back to it.
Somebody should say about something about
Oh,
Frank, are you satisfied?
I wanted to ask another question. So maybe that's...
Okay, so let's have Kamlesh.
Hi, Kamlesh from GP UK. These are great discussions about how we create a registry, and we've got lots of experience. We're here asking for a diabetes registry, and I agree it should be primary care. They coordinate the care. Maybe we shouldn't be talking about a diabetes registry, but a chronic disease registry. Because a person with diabetes, 85% will have another disease. And we don't want the cardiologists fighting for it, nephrologists. Now we've got concordant diseases, discordant diseases, and a core set of disease areas. Maybe go to our governments for an ask for a chronic disease registry where you can coordinate care for all those diseases. The evidence base is strong. Unless you have electronic health records, you can't do a call recall system. Randomized controlled trials show the call recall system will lead to better outcomes. You can't do that without electronic records. In terms of data capture from secondary care, from death registries, that can become later. Minimal data set, as mentioned earlier. We have regular feedback on 8 care processes. Feet checked, eyes checked, blood pressure below 140/90. HbA1c below some percent. It's simple things. Start with the simple things, and then you can create all the very, very sophisticated things later. In terms of the ask to the government, when should we be going? We really should be going now. We've had 2 years of disruptions in care for people with diabetes. Unless we can monitor what happens to these people, we won't know. More people are going to die because of the disruptions in care than people have died of COVID. And I think we need to make that point clear to the governments and say we can't wait 5 to 7 years, as Robert said. Thank you.
Yeah,
thanks, Kamlesh.
Yes, Pinar, then Robert.
Very sorry. Yeah. Would you?
Pinar, you go first.
I want to say something about this issue with cancer. I think we're not good with I mean the professional governance here represented in this room, and also EUDF as an organization, for instance. We should be much more proactive we're not good in communicating risk to our patients individually as doctors, but I see now that we're not good either in communicating the inherent risk of this chronic disease outbreak, sort of, with this aging population to the decision makers and policy makers, because they will be then the ones who go to the payers and say, do this and pay for that. So I think it's a very big task of the professional governance to bring over this message that diabetes is as dangerous and as bad for population health as is cancer, because at first sight, of course, cancer has an effective and sensitive notion to people, and diabetes being an insidious disease because elevated H1C doesn't hurt unless you get amputated or blind. That is something that policymakers, I mean, are not aware of, and we should be the ones to bring that message over.
Yeah, Carol Go. I mean, I have different questions online too, but she says, and I will read exactly what she says. Probably it has to do with the invisibility of diabetes in daily life. But I really liked Kamlesh's comment. It's actually registries of chronic diseases we need, but I also liked what Pinar said before, diabetes as the pilot, as the case, because as the index case indeed. Before I come to you, Peter, you were going to comment.
Yeah, the last 2 questions related to the question of registries and how to use it for diagnosis and so on. You described the dream. I would say the registry should be. There's a pilot project in Germany with the idea to bring the data from all the ambulatory working physicians together in a data integration center, and then to model the lifestyle, the morbidity of the patient. And so taking it from the dentist, from the GP, from the specialist, from the hospital, and then if the patient, due to the modeling, is identified as pre-diabetic or having a hypertension risk or cardiovascular risk, and the patient is going to the dentist or the gynecologist, then a message should pop up to say, okay, there is something, and maybe you act as physician or you transfer to the GP and so on. This would be our dream. And that's why Tadej was defending Germany, and I was so harsh. This dream doesn't exist. Yeah? There is DPV and there is SWEET as excellent registries, but not national. Yeah? The interconnection to the national is missing. And the bad thing is the state is collecting this data. We have disease management programs. And if the patient is part of the disease management program, every 3 months a minimal set of data has to be collected. And nothing is done with it except used for accounting and payment for the physician. And this is what I think, this is actually a disaster because we have this data, but we don't make them actionable.
Katarina, can I come back to you? And how do you do it in Sweden?
Yeah, I think it's very interesting to hear all your comments here. And I think what we heard from the UK here, with a minimum set of very important, those are exactly the ones that we have from primary care in Sweden. And today, when the National Board of Healthcare, they're preparing a report from COVID, the COVID experience, what is lacking in all chronic diseases. For diabetes, they use the diabetes register, the same output that the unit can use. So it's you use the same data, you talk about the same data, and that makes, if the Board of Health and Welfare use it, my clinic use it, the other primary healthcare unit use it. That makes a very strong case.
Oh, Chantal, may I come back to your handshaking? Because it made me think about the incentives. And I mentioned also in the recommendation we should put the incentives in the right place. And incentives should trigger good behavior of the system. So if you are paid for shaking hands, I think that's the wrong incentive.
If the minister is listening, I didn't say that. So.
No, but it's a great example. That's why I'm using it. Because the system will work according to the incentives. So if you don't put the incentives in the right place, you will never succeed with or without a register. And so that's why I think the incentives should be put into the direction of providing better care with better outcomes.
Yeah, chronic
so it should
disease
be an outcome-based incentives.
Yes.
And I think then you can put the order in the right place.
What is interesting, and I come to you immediately, but it's interesting is that, Jeanette, for our people with type 1 diabetes, we do have disease-based reimbursement, for instance, in our hospitals, where we do have payment for nurses, whether they see people online, whether they see people face-to-face, and that seems to work. There also, very often, are the very successful registries. Think of DPV, think of SWEET. Can I just come to you, JDRF, research, awareness about type 1, how important are registries there?
They're super, super important. And I think there are different types of registries, again, coming back to my point earlier, that can be used for different things. For instance, the minimal set that is looking at certain variables where the key outcome is a change in care or benchmarking. But then we're also talking about these registries that could be linked to electronic healthcare record and take all types of data and do prediction modeling, stratification of people, understanding profiling. There are two different types of things. And perhaps we need both, perhaps we need one huge one. That's what Rob doesn't want because it's too big a step. But perhaps we need to do it stepwise, but we need both. We need both the research piece and the implementation, benchmarking to change healthcare and the policy piece. But in terms of type 1 diabetes, SWEET is doing a fantastic job. They are actually moving the needle, which is absolutely amazing. One thing that we would think is missing is that 50% of people with type 1 diabetes are diagnosed as adults. Where are they? Where are the newly diagnosed adults? Where do we collect them? EUDF is trying to do something similar, but EUDF is a project that is currently looking for sustainability and how to progress in the future. But there are still gaps in the type 1 fabric, so to speak, even though that we are doing all the things that you pointed out. So I think that even for type 1, and of course, type 1 has a tendency of being overshadowed by the type 2 because of the sheer importance of the type 2 pandemic, epidemic, endemic, size. But we as a type 1 community need to push further, and we need to make sure that the data that is available, as some of the speakers have said, that we actually start using it. What are we waiting for? And I agree with Rob, we can't wait 5 to 7 years. I don't like the stepwise approach. I like the big strides. But again, ambition, come on, let's move now.
Excellent. Please, introduce yourself.
So I'm actually living with type 1 diabetes, and I come from Bosnia and Herzegovina. I'm also a nurse, so I have that patient and medical worker perspective. So I think in Bosnia until now, there were like 7 projects that tried to make a registry, and every single one failed. And I think like it's different when you look at under-resourced countries. What we all talk about in theory is very different when you actually come to the place and when you try to do a practical implementation of all of these things, because you get into so many barriers that you haven't expected. So, and no one is taking the responsibility. You know, no one wants to take the initiative to have that communication with maybe some resource countries who could help with certain problems regarding diabetes and registries. So my question would be, how would you facilitate resource countries, or generally, how would you facilitate the wider community helping under-resourced countries to get that support to do, I'm going to call it a project like making a diabetes registry? You know, how would you solve those problems in under-resourced countries? Because we have used data, for example, if you look at the EUDF Atlas, their like numbers, they're very off. Like as a person coming from that country, I can tell you they're very off. It's not that I'm judging, it's just I'm saying, and they're not representing the situation. So we were not able to use them, for example, to get Abbott to register the product Libre in Bosnia. So we can get a refund of Libre, but the product is not registered because they think they don't have enough patients / customers. So I think we in small countries find it very beneficial to have data because we could use it for initial steps to get better care. And I think like in this moment, the facilitation of those changes is that we need someone who is stronger in that field to help us work in that field, because we just don't know how or can't. So.
Yeah. Can I just start by commenting? I think whether you're a rich or poor, a big or a small country, you need champions. You need champions to push. And the guy behind you, Frank Nobles, is, for instance, one of these champions in my country. Pushing, pushing, pushing. And we don't get paid. I mean, he and me, we don't get paid for that. So you just need people. And Katarina, perhaps you can comment how, you know, you said it was also the healthcare professionals who started it. So were you paid, or were you also doing it as champions?
So there were definitely champions to start with, and there's still, we had a 25-year celebration, and all the old champions and newer champions came, and it was with all the representatives from all parts of Sweden. So it's really, you have to find a group of people in your country that really want to work with this, and we can share our experience, of course, from Sweden, if that can be an help, but you need the group around you.
Yeah. And you need people to start it, even without money. I mean.
May I say just that?
Yes, please, John.
No, just to say that to start, perhaps we are discussing national registries, full population registry, but also if we want just to know or to have an estimate of the number of people involved, we can start always with sampling methods, we can start with small studies, regional levels, because that's also possible to start, and then people would feel the need to know more, and that would push also the system to work towards a bigger and more robust system. But if you just start from the beginning and you don't have any resources and you want to make a national registry, even with a small number of parameters inside, it might be a too much difficult task to start.
Yeah, that was my second question, like how to start that process in an under-resourced country.
Mm-hmm. Can I propose that you contact us at the European Diabetes Forum, and so we can bring you in contact with initiatives that have started, and we can give you examples of best practices and help you get started. So do contact us.
Thank you.
Yeah, so maybe you can add, because
yes,
peer-to-peer support I think is extremely important, so partnering with people in high-income countries that have the experience and are willing to support. And there will be also resources made available through other parties where additional funding can be requested to get started. So I think there are opportunities, and I think Chantal can direct you in the right direction.
Yeah. Frank.
About champions, in fact, in Belgium, our super champion is Chantal. I have a remark on apps. I doubt if it's necessary to license and reimburse apps and to look at them as if it is medication. We are looking, I think, too much through medical glasses. If you ask patients, what they just want to do is to use the latest apps, and they want to have your opinion on their quality. So we need a group of people, and they can be in the diabetes associations, I think, that follow these apps, that many of them themselves have diabetes, and that look at the quality and give advice about this. Because otherwise we will wait far too long before they are licensed and reimbursed. That's my opinion.
And this is very interesting that you say it, because this represents the discussion we currently also have in Germany and had in the last 4 years, because we had this group assessing diabetes apps, but this group was working, it was an enormous workload, and then suddenly it was not funded anymore. So it totally broke down. Then we have the Digitales Versorgungs, Digital Healthcare Act, and this initiated the total opposite, high barriers for licensing apps, and only allow licensed apps in the healthcare sector. So from a very wide use, we go to a very limited use. And we don't have the experience yet. Is it good or not? In the moment, it supports evidence, it supports data safety, which is becoming more and more important. So there are also a number of pros, and I think a large number of pros on a side saying we need a license, we need to have studies, we must be sure that they work. But I also totally can understand the opposite side.
Yeah, the problem, Frank, is with the medical device regulation. We have a stupid app that is just translating the figures of the consensus on management of hyperglycemia. And that is considered a medical device. And so now, we had a look at it. It will cost 120,000 euro just to get it up to speed and all the rules and regulations and la-di-da-di-da. So, we will not make it anymore. Yeah. Anyway, final comments.
I'm from Georgia, professional endocrinologist, founder of Diabetes Center and chairman of Diabetes and Endocrine Society. During my practice, with you recognized old enemies. Diseases, ignorance of education, and healthcare, system, old style, working. Now we need new friends, new heroes. You said very well. We need heroes not in my country. For example, Prime Minister of Georgia is my patient. Some ministers are my patients. It's a good for patients, for other people. We all people with diabetes, sweet friends, European people with diabetes, they need new friends. For example, First Lady, members of European parliaments, your instructions, direction, our best friend Stefano said the day before yesterday, peace, prosperity, and progress. And this process will be uniform for all European countries. We should forget about old inertia. And together we have a chance to be much more stronger. Thank you.
Well, what can we say? Thank you very much. We are at time, dear friends, and it was amazing to see a full room for a topic that is not so, usual to be seen at the European Association for the Study of Diabetes conference, namely a policy topic and where should we go and how should we organize our care. And so it was really humbling to see the people in this room and again to hear the wise words of our panel. Again, I need to thank all the panelists, but again, a special thanks to Rob, João instead of Angus, and Peter, and all of the people who participated in the strategic forums. Can I just ask those people who participate in the audience of the strategic forums to stand up? Because then I will applaud you. Thank you. I mean, these people did a lot of work, so thank you all, also Tadej and Pinar and Jeanette and Katarina for all of your hard work, and Katarina for sharing so generously all your best practices of the Swedish registry. I will end by thanking you all, by inviting you all to go to eudf.org to follow our practices. And, you know, talking about data, talking about modeling, there will be important news today, an initiative supported by JDRF, the T1D index. The manuscript is already online in Lancet Diabetes Endocrinology, but Jeanette, perhaps you want to say a few words on this so important initiative.
A very, very few words. So, as someone in the audience pointed out, the type 1 atlas currently isn't perhaps giving a full picture of the burden of the disease and what type 1 actually is. And JDRF, together with Life of a Child, IDF, and ISPAD, has been driving an initiative for getting better understanding of how many people actually have type 1, and also how many people had type 1 but were lost because they never got treatment. Those who died of DKA, those who died undiagnosed, how many are those? And use those numbers to actually highlight the importance of the disease and how much we definitely need to act on it now. So at 5 o'clock there will be a press release on this, and I invite you to stay tuned and listen to it, because type 1, there's quite a big gap that we don't know about, and it's better for us to understand the full picture. Thanks.
Thank you very much, Jeanette, and thank you all for attending, and have a good EASD. Thank you.